If you work in emergency medicine, you know that feeling.
Oh,
The
yes.
sight of those blue flashing lights pulling up, and you realize the patient is a child. The stakes are just instantly higher.
And the cognitive load is immense, even if it's not something you see every single shift.
Welcome to the deep dive. Today, we are cutting straight to the essential knowledge for achieving excellence in pediatric emergency medicine. Our mission is to really dissect the roadmap laid out by the Royal College of Emergency Medicine's Specialty Learning Outcome 5.
SLO 5.
Right, SLO 5. And this isn't just about clinical knowledge, is it? It's about applied judgment, especially when you're managing real complexity.
That roadmap is vast, you're right. The challenge isn't the basic ABCDEs we all know, it's the integration.
Integration of what, exactly?
Well, SLO 5 covers children of all ages, from tiny neonates right through to adolescents, and it explicitly includes those children who come in with really complex medical and social needs already. So it demands this total integration of clinical skill, leadership in a resus, safeguarding, and, deeply compassionate family care.
I think that's the key distinction then. SL5 isn't just about proving you can calculate a drug dose. It's about showing nuanced judgment and that you can lead a team under enormous pressure.
Exactly. And strategically, the RCEM assessment program, it mandates that you continually gather this evidence.
Right.
For SLO5 competence, it has to be in each year of training.
Even when you're on, say, an adult placement.
Yes, even then. You have to actively seek out a mixed economy of assessments. You can't just have a flurry of activity in your pediatric ED block and think you're done.
So let's focus on that clinical mandate first.
Okay.
Mastery of Domain 2 capabilities, diagnosis, management, all that is the foundation. But I was struck by the comparison to SLO3, adult resuscitation. Why is that so insightful?
Well, it's fascinating because SLO3 gives you this huge detailed amount of content, specific protocols for MI, for stroke, for sepsis in adults.
Right, it's very prescriptive.
Very. But SLO5, it kind of lacks that. And that's by design, because every child is so developmentally unique. So success really hinges on your ability to transpose those high-level critical care skills onto pediatric physiology.
Transpose. What does that mean in practice?
It means if you fail to transpose them correctly, your adult skills become dangerous. For example, in an adult in shock, you might immediately reach for pressors or massive fluid boluses.
A standard reflex.
It is. But in a child, that reflex fails. Their stroke volume is highly dependent on their heart rate. They crash differently. You have to show this nuanced judgment. You're looking at age-specific variables. Is this tachycardia compensatory? Is their blood glucose the bigger problem right now?
That immediately clarifies why the assessment tools are so specific. You need evidence of that judgment, not just a checklist. So speaking of evidence, what are the mandatory tools we should be focusing on?
Well, the big ones.
The ESLE, the Evaluation of Specialty Learning event, that seems essential for documenting real leadership, doesn't it? Especially in a pediatric trauma or a big resuscitation.
Absolutely. The assessor is looking at how you allocate tasks, your situational awareness, how you manage the whole team.
And then there's the case-based discussion, the CBD.
This is where you really shine in complexity. A CBD is perfect for showcasing how you manage an ethical quandary, like, say, termination of resuscitation, or handling a complex social history, a safeguarding dilemma. It proves you get the socio-legal context, not just the diagnosis.
And we can't forget the MSF, multi-source feedback. This seems critical for capturing those non-technical skills.
It is. We're talking about empathetic communication with families who are, completely distraught, and showing robust collaboration.
Which often means acting on concerns raised by nursing staff, right?
Yeah.
The people who often know the child and family best.
100%. And remember, before any of this, you have the mandatory training. APLS or EPELS is non-negotiable. And your safeguarding training, you have to be up to date on levels 1, 2, and 3. That underpins everything in Domain 7.
Okay, so with that assessment framework covered, let's get into the clinical nuts and bolts. The foundation is that rapid, structured evaluation. The ABCDE approach is still core, but the execution is much more subtle.
The subtlety starts in the first 30 seconds. That look, listen, and feel assessment. The expert approach to a distressed child is just radically different from an adult.
How so?
You have to prioritize observation, the look and the listen. You do this while the child is settling, maybe on a parent's lap, because the moment you touch them for the feel part, they might start screaming.
And there goes your respiratory rate assessment.
Exactly. It invalidates everything. So you gather all that non-invasive data first.
Okay, and this is where the UK-specific guidance gets really high stakes. The UK Pediatric Early Warning Score. or PEWSES. You're saying achieving SLO5 means understanding and actioning all 4 escalation triggers, not just the number.
That sophistication is paramount for safety.
Yeah.
The numerical score and a drop in consciousness, AVPU, those are the straightforward triggers.
Right.
But it's the 2 non-physiological triggers that show true professional judgment.
Okay, what are they?
The first is the clinical intuition trigger. This is when a clinician, and often it's the senior nurse with that incredible radar voices that concern, they just say, they don't look right.
Even if the numbers are fine.
Exactly. That concern must be documented and actioned for escalation, even if the score is low. It validates the expertise of the whole team.
And the second one?
The parent concern trigger. This is a powerful, independent safety net mandated by the Royal College of Pediatrics and Child Health. If a parent or carer voices a significant concern, it must lead to an escalation of care.
Regardless of the PUWS score.
Regardless of the score.
Great. How often, practically speaking, do we see that clinical intuition trigger being used versus just the number? Is there a risk of over-escalating?
That's a great question. We should be aiming for a culture where intuition is treated as valid data. The risk of over-escalating, a false positive, it's minimal compared to the catastrophe of a misdeterioration.
So for SLO5, you're assessed on how you respond to these non-numerical concerns.
Absolutely. You, as the leader, have to document that concern and validate your team's judgment. It shows you understand that a child's physiology can just fall off a cliff.
And to help build those visual assessment skills, there are resources like the Spotting the Sick Child online module, right?
Yes, which has huge amounts of clinical footage. It helps bridge that gap between low frequency and high impact.
We also can't overlook the developmental side of assessment, the soft skills.
That's where competence really shows. It means knowing how to use distraction, whether that's knowing about Bluey or Paw Patrol for a toddler or football teams for an older kid just to get a baseline exam done.
It's about building rapport in seconds.
And using age-appropriate comfort measures during procedures. Simple things, but they have a huge impact. Skin-to-skin contact, swaddling, or pre-procedure sucrose for an infant before you try to get a cannula in. It's about minimizing trauma.
Okay, let's pivot now to what you call domain expertise. Eye safeguarding, domain 7. For UK practitioners, this is just non-negotiable.
It requires a deep understanding of national policies, the choreography with external systems, children's social care, police child protection units, all of it.
And the core requirement is escalating based on judgment or suspicion, even without absolute certainty.
Yes, you have to be proactive, and that requires a departmental culture that fully supports staff who raise concerns, that gets senior pediatrics and social care involved immediately.
And because these situations are so incredibly high stakes, the documentation has to be medico-legally rigorous.
The standard is highly specific. First, you have to record injuries accurately using diagrams and photographs. That provides physical evidence.
Right.
Second, you must note the exact words used by caregivers when they explain the mechanism of injury.
So it's not enough to write, caregiver stated child fell downstairs. You have to record the phrasing verbatim.
Precisely.
Right.
Because recording the exact phrasing captures subtle inconsistencies or changes in the story over time. And third, you document your entire decision-making process. Who you consulted, what advice was given, your rationale. It's an audit trail of professional due diligence.
And there's a communication piece to this. If a referral is made, you have to tell the parents, sensitively.
Yes. The focus has to be on the child's safety, never on accusatory language. That sensitive communication is a core skill they're looking for in your CBDs and your MSF.
Okay, let's shift to domain expertise 2. Managing complexity. This is a huge part of modern PEM.
A massive part. Competence explicitly requires managing children with intellectual and developmental disabilities, or IDDs. They're high users of ED services and often face serious health disparities.
And their presentation can be completely non-specific, or they just get overwhelmed by the sensory chaos of the ED. So what does implementing reasonable adjustments actually look like?
It looks like reducing sensory input right away, finding a quieter space, dimming the lights, asking the team to speak one at a time. Using AAC methods, visual supports, picture cards for nonverbal or autistic children.
And I've seen this stressed before. You have to allow sufficient wait time for them to process. Resisting that urge to fill the silence is critical.
Absolutely. And then you have the high acuity technology dependent child.
The children on home ventilators. with trachea.
Exactly. For them, your initial assessment has to prioritize troubleshooting the equipment, establishing their stable baseline settings, ventilator parameters, normal blood gases, before you even treat the current illness. The problem is often the machine, not the child.
And this all comes back to leadership, which is why high-fidelity simulation is mandatory for SLO5.
SIM is where you address those low-frequency, high-stakes events, a complex arrhythmia, massive hemorrhage, and a tiny child. It's where you refine your teamwork and communication in a safe space.
And finally, that brings us to the most profound ethical challenges surrounding the termination of resuscitation.
This is the ultimate test of ethical leadership. A trainee has to be able to balance beneficence against the harms of dyskinesia, a prolonged, painful death from futile care.
And the curriculum gives clear prognostic indicators, doesn't it? You need to know when to stop.
Yes. A lack of response to intensive resuscitation for more than 10 minutes carries an extremely poor prognosis. But it's always contextual. You have to consider mitigating factors like severe pre-arrest hypothermia or a drug overdose. It requires real-time consultation and real ethical maturity.
And this encounter has to end with the highest standard of compassionate communication. Managing family presence during resuscitation.
Yes, you must allocate a dedicated staff member just to support the parents and offer them the sensitive option of holding their child as care is withdrawn. It humanizes an unimaginable experience.
So what does this all mean for you, the practitioner?
I think attainment of SLO5 is defined not just by how well you manage the pathophysiology, but by your capacity to manage all of it. The social, the developmental, and the ethical complexities that are just inherent in pediatric emergency medicine.
So our key recommendation for practitioners focusing on SLO5 is this. Prioritize documenting your professional judgment. Actively record when you acted on that clinical intuition trigger or the parent concern trigger. Show your assessor the depth of your clinical wisdom.
And treat your safeguarding documentation with absolute medico-legal rigor. Diagrams, photographs, and meticulously recording the exact words used by caregivers. That's the difference between competence and real excellence.
And we'll leave you with this final provocative thought. The RCEM curriculum explicitly requires leadership that extends into bereavement support. Your work at the ED ends when the patient leaves, but for a bereaved family, their journey is just beginning. Consider the profound, long-term impact that your interaction with them has on their entire grieving process, your capacity for compassionate, structured communication in those moments. It is truly a lasting component of care.